Again, welcome to our August webinar, Time is Tissue, the optimal timing of initiation of milk removal following delivery. As I mentioned, we have a lot of great information for you all. We are going to start with a couple of updates. Our updates. There are going to be 2 opportunities for Georgia. They're Georgia-specific Speak Up trainings through IPQI. They will be in October and then again in May. So we're giving you lots of heads up. We will have more information to come, but just letting you know now that those are going to be opportunities and they're Georgia specific. And these will be for people who have not yet gone through the Speak Up training. And if you mute as you come in, it would be great. Thank you. And then our other really exciting update. Okay, 1 second so people can mute. 1 second. There are our first 2 micro lessons are loaded on Train and ready to be accessed. So there's a little screenshot I gave here on how to access them. You need to have your Train account. So if you haven't created that yet, go create that account. There is a tool on Teams that can walk you through creating that account. Then you'll go into your Train account and there's a search bar. Here it's circled in green. Just put GaPQC in there. So GaPQC and hit enter. And then that will bring up right now the 2 micro lessons that are under GaPQC. So you'll see there, they're labeled micro lesson 1 and 2. These only take a few minutes to go through. You can access them at any time. The way that we're putting them up is that they are going to be related to that month's webinar topic. So it makes sense to do them as the months go along and kind of keep the topics together, but you don't have to. So they stay there. If you don't do these in August, they're still going to be there in September. So you can do them at any time. But again, they only take a few minutes. You'll go through the video-based course, and then you'll come back and do an assessment, and that's how we track that you are completing these courses. So we're excited. Huge thanks to Georgia AAP for all the work they've done on working on these micro lessons. So after this webinar, you can go hop in there. If you have any questions about Train, reach out to me. My email, of course, will be at the end, and I can put it in the chat as well. Now we're going to move on to a presentation from Dr. Patel looking at our July audit results.
Thank you, Kimberly. And hi, everyone. We're really excited to share kind of what came out of our first audit. And I wanted to just refresh for some of us that are joining this for the first time. You know, our goal for this Optimizing Newborn Nutrition Initiative is really to have quality improvement at the core. And you probably have seen this when we shared this last month, but we've structured this initiative with kind of a broad key driver diagram to address some of the primary drivers of what we hope to achieve at the end of 2 years, with the primary aim being a focus on improving human milk as a first feeding in Georgia newborns. And related to these primary drivers are interventions and monthly webinars that are going to touch on many of these interventions and micro lessons that tie in. And so we hope to bolster some of the changes you will be making and change ideas with these webinars and micro lessons on Train. And so today we're really excited as Claire Eden with Georgia AP is going to introduce our 2 speakers to touch on our first educational webinar that is going to be tied to several of these interventions that address some of the primary drivers. And you'll see more of this hopefully as we build on. We touch on all these areas. Now, some of these, what we hope is that you're inspired for some of these potential changes that you can take back to your hospitals and work on. We realize that many of you have been working on a number of these different interventions, and so this is really going to be individualized to centers, and we hope to help you with that. Now, I wanted to share this. We've really been excited with the engagement of the number of hospitals. This is actually a map of the states that have worked on breastfeeding and newborn nutrition that came from a review that was published by Drs. Meg Parker and Aloka Patel a few years ago. And we actually have the largest number of hospitals that have been participating, at least based on this review, on a newborn nutrition initiative at 26. So that's really exciting. When you look at the next highest is actually from Florida, which worked on it a few years ago. So we're really excited to have a number of hospitals that are working on this initiative. Now, as we've talked about part of quality improvement at the core is we want teams, we need to have data collection to know where we are and how we're meeting our goals, but we want this to be minimal. And we want teams to focus on learning, on improving, and not spend all their time on data collection. And so our first audit in July was tied to minimal data collection. And we want this to be applicable to any birthing hospital or hospital in Georgia. And so this is can apply to mother, baby, or the NICU. And we are going to reach out to some of our children's hospitals because they do have unique patient populations of how we can make this most relevant to them. So this was, our audits are tied to really 3 key measures and trying to give a sense of where we stand with 3 measures. And those 3 measures are human milk as the first feeding, which is our primary measure for this initiative. Any formula exposure in the last week, if the babies are in well newborn, where they're there for only a few days, then within their stay in the hospital. And then the third, which I think will tie into our talk today, is timeliness of breastfeeding and breast milk expression. And so those are the 3 key measures that we have that I'm going to share with you today. So we had a really awesome completion rate. We really wanted to congratulate our hospitals on doing this audit. This was the first audit from July from our hospitals. We had responses from 20 of the 26 hospitals, so about 80% of those that have signed up. And many of our hospitals are participating in both the well newborn and NICU special care nursery setting. And so we had 28 different units. I think this highlights the diversity of the different settings in which our hospitals participating in. So we have crafted this initiative to address both well newborn as well as NICU or special care nursery nutrition needs. So this is how we did with our first feeding. And I think one of the things that we were reflecting when we had our neonatal subcommittee call last week is really, if you look in Georgia, and we wanted to know how are we doing in July of 2022 with nutrition, there's really no data that we have that can tell us kind of really timely assessment of addressable impacts that's available. And so this is really a nice snapshot of how our centers are doing. And so among the 28 units that audited 10 infants, this is the overall summary of how those units did, where about 72% of infants audited had human milk as their first feeding. You can see on the graph below the distribution. So about 20% of the units, all 10 of those infants had human milk as their first feeding. You can see that many had a majority, but not all of those infants, and then some were relatively few at it. And this is going to be our primary measure for the overall GaPQC, where we want to track this and see how we can move that. And what we hope is that over time, the distribution here of this graph starts to shift to the right, where we see more of these infants that are being sampled are getting human milk as the first feeding. That could be either mother's own milk, ideally, or for a lot of our NICU settings, donor human milk. Our second measure is formula in the last week. And so this is any formula exposure within the last 7 days for infants that have been hospitalized more than a week, or for the duration of the hospital for infants that were hospitalized for shorter durations. And you can see that this was pretty high. About 62% of infants had some formula exposure in the prior week. And you can see the distribution here across the different hospitals. And none of the hospitals that were audited had 0 infants, at least based on the data we received, that had formula exposure. And the third was timeliness of breast milk expression or breastfeeding. This was our third measure, where you can see about 44% of the infants audited had breast milk feeding or breastfeeding or expression of breast milk within 6 hours of birth. This was a little bit, I wanted to acknowledge that this was an area where we had a little bit more struggle with data collection. This is not something that's routinely collected for some of the hospitals. Here's some of the feedback that we received from the hospitals on this measure. And I think this, for many of you, this might be, you might share some of these sentiments where it's difficult to know for patients who are not feeding when actual expression occurs. There was a lack of documentation around this because or if infants are transferred, the lack of documentation of birth hospital records. And one hospital noted that they've asked, because this wasn't, they didn't have data for the IVSLC or the lactation consultant to include this in their note. 13 of the hospitals noted no challenges and easy to complete. And so we realized that this third measure may be difficult for some hospitals. I would consider and think about today's webinar about how important this might be for your improvement efforts, and this might involve making efforts to try to change so that this is being collected. for some hospitals where this is really a challenge, it may be where you're not able to provide this data, and we understand that. But I think it's worth considering efforts to try to collect this as one of the 3 targets for improvement. Now, this was our audit, and these are the measures that we looked at, which we thought were kind of key policies and maybe more structural assessments of our centers. These are things that we're not going to be assessing every month, but at least to give you a sense of how we're doing as the Georgia Perinatal Quality Collaborative. And so you can see sites are doing relatively well on policies on milk collection, storage, administration, physicians being part of the team. But then as you go down, there are areas, for example, policies on donor human milk use, skin-to-skin care and early lactation, on breastfeeding education for new staff and continuing education, and on supplementation and medical indications and guidance for supplementation, where I think there's lots of opportunity for improvement. And we really do hope, and our goal is to help hospitals develop or give ideas of what needs to be in these policies. One of the great things about collaboratives is sharing, and we hope that other hospitals, this can be a resource for other hospitals to potentially connect with each other that have these policies to make it easier for those that don't to develop these. And so these are our first dots. So July 2022, this was our first audit on some of these structure measures. You can see these dots. We're going to have the same type of measures on a more frequent interval for those 3 process and outcome measures. And what we hope to show over time through this, and we're going to do this about every 6 months, is that we're able to move the needle where we see improvements, particularly in some of these policy measures among hospitals over time. And our goal, and we want to support hospitals in developing these policies. We think this is a key aspect of moving from changes in testing to implementation and to have it ingrained into the system. And so this is something that we're going to be tracking. And in January of next year, we'll have another audit to see how we're doing with that. Now on to SMART aims. We mentioned last month that we touched a little bit on SMART aims and kind of what our goals are. And for the overall GaPQC as our overall collaborative aim, we started with kind of this SMART aim of increasing the percent of newborns with human milk as a first feeding. We had a lot of blanks at that time because we really didn't have baseline data until the first audit. And this is going to be what we're going to be tracking at the state level. This may or may not be what's the SMART aim that you and your hospitals are going to be working on. And we really do think, and we want you to think about what is the opportunities that you might address. It could be this, it could be potentially related to reducing formula supplementation when it's not really indicated, or maybe even timeliness of breastfeeding or breast milk expression. And so I wanted to, as we finish up, touch on some of the key aspects of what makes SMART aims smart. The first is that they should be specific. Be specific about what you want to improve on, what you hope to achieve. They need to be measurable. And so one of the key things we started out with is if we're serious about quality improvement, we have to be able to measure how we're doing and then use that as a guide to see if we're achieving those targets. And so to set numerical targets that we think are realistically achieved. These should be relevant to improving patient care experience and outcomes. And we want to improve nutritional care and outcomes for infants here in Georgia newborns. And then finally, they need to be time-bound of when we think we might achieve the aim. And for this initiative, we've set a 2-year timeline. We kind of pushed it back from our earlier start, and our goal is to give ourselves 2 years to try to achieve that. So how does that relate to our overall GaPQC SMART aim? We want to, as being a specific part, we want to increase the percent of newborns in GaPQC hospital-based audits with human milk as a first feeding. We realize these audits aren't sampling or reflective of the whole population. They're not weighted by the number of patients in the center, but we think this gives us a snapshot of how we're doing. Every hospital is weighted equally here. Our first point is 72%. We're going to set our baseline after the next month's audit as the median between July and this coming month, and that's going to be our baseline. And we're going to talk next month about what we think our target should be, and what we really think as a collaborative, what our goal would be. And we're going to do some live polling to get a sense from all of you of where we should set our target. This is relevant because we really want to improve breastfeeding outcomes for babies and mothers in Georgia's hospitals. And all of you are here, many of you are here because this is really something that I think many of you are passionate about, and we want to help support you in terms of improving these outcomes. And then the timeline is to finish this in at least to try to see what we can make and improvements we can make by 2024. So this is our SMART aim, and we'll come back to this in next month and put hopefully to have a SMART aim that's finalized for our Perinatal Quality Collaborative. But I put this example because I also think this is the time for you as in your teams to start thinking about what are your SMART aims going to be in your centers. You have your data from your first audit. That's your first stop point. You might think about which of those 3 measures, or maybe there's additional measures you're collecting that you want to work on and try to address. And we're going to start over the next couple of months on hearing from centers on what you want, and we want to hear what your SMART aims are going to be. They could mirror this, or they might be different, which is okay. And so that's something that we're going to come back to next month. And so with that, I'm going to stop presenting, and I'm going to see if there's any questions over the next couple of minutes from our teams before I hand it over to Claire Eden, with Georgia AP is going to introduce our 2 speakers. Okay, well, thank you all for really your efforts, and we're really quite delighted with the amount of engagement we got with this audit, and we look forward to on seeing how things go over this month. As always, please reach out to Kimberly if you have questions, or to myself. So I'm going to turn it over to Claire to introduce. We're really excited for our 2 speakers today.
Thank you, Dr. Patel. I'm really pleased to introduce a faculty for the educational portion of today's webinar, Dr. Sandra Sullivan and Dr. Leslie Parker from the University of Florida. Go Gators! Gainesville, Florida is my hometown. So we'll start with Dr. Sandra Sullivan. She's a clinical associate professor in the Department of Pediatrics and Division of Neonatology at UF. She's held several roles, including founder and director of the UF Health Center for Breastfeeding and Newborns, the medical director of lactation at UF Health Shands Children's Hospital, and is a former medical director of the UF Health NICU follow-up clinic. She is board certified in pediatrics, neonatal perinatal medicine, and lactation. Dr. Sullivan serves as the chapter breastfeeding coordinator for the Florida chapter of the AAP, is a fellow of the AAP, and a member of the Academy of Breastfeeding Medicine. Dr. Leslie Parker is board certified as a neonatal nurse practitioner and is associate professor in the College of Nursing at the University of Florida. She has an active practice as a neonatal nurse practitioner in the NICU at UF Health, and also does a lot of research, and her research involves nutritional support of the premature infant with an emphasis on breastfeeding and infants in the NICU. And I believe, Dr. Parker, you'll be starting us off.
That's correct. So good afternoon, everyone. On behalf of Sandra and I, we really welcome you to this presentation and hope that you get something that you can take back to your hospitals. So we really want to talk about early milk removal, and I think that this is a key to successful lactation. And we're going to talk about both the healthy term mother as well as the mother that delivers a critically ill or preterm infant. Next slide, please. So I have no financial relationship to disclose, and Dr. Sullivan has to disclose that she is a non-employee consulting contract with Government Affairs Department of Proactive Bioscience and Company. So I'm not going to spend much time on benefits of successful lactation because I think we're all very aware of that. But we know that in the very low birth weight infant, it decreases the risk of certain morbidities such as necrotizing enterocolitis, late onset sepsis, bronchopulmonary dysplasia, and retinopathy of prematurity. In both the preterm and the term infant, it increases the developmental outcomes, improves them. It also improves the health of babies that are born healthy in term. They have less otitis media, they have less respiratory infections, and less diarrhea. And we don't think about it as much as we do for the benefits of infants, but breastfeeding also benefits the mothers. And so mothers that breastfeed have a decreased risk of ovarian and breast cancer. They have a decreased risk of hypertension and obesity, as well as diabetes. Next slide, please. But we have a problem. And I think as we look over the entire country, we are doing a really, really good job at initiating. So in all of our populations, and I'm going to talk about the term infant, the preterm infant, the late preterm infant, and the critically ill infant, all of them really initiate expression or initiate lactation at greater than 80%. But it falls dramatically after that. So we're initiating, but we're not continuing lactation. So mothers that are breastfeeding healthy babies, at 3 months, only about 43% of them are continuing to lactate. In our very low birth weight population, less than 50% of those infants are receiving their mother's own milk at hospital discharge. And at 6 weeks, most of those mothers are not producing sufficient amounts of milk to provide optimal nutrition to their infants. When we think about the late preterm infant, even fewer of those infants than term healthy infants are lactating at 1 month, only 63%. And if we think about those infants that are born term, but are separated from their mother because they may be critically ill and admitted to the NICU, we have no idea how those mothers are doing. But I can imagine that it's not nearly as good as the healthy breastfeeding mothers. Next slide, please. Next slide, please. So I think the root of the problem, why we're having so many mothers stop either expressing milk or breastfeeding, is that there's an insufficient milk supply. So this can either be a perceived insufficient milk supply by a mother that's exclusively breastfeeding. She may have an infant that's crying quite a bit, and she says, oh, I don't have enough milk to be able to provide my infant full nutrition. Or in the NICU, mothers that are pump dependent may not be expressing sufficient quantities of milk. And this is the main reason that mothers across the board stop lactating. Next slide, please. So I would argue that this problem of low milk supply in all of the population begins within those first 14 days. And that's what really the evidence show. But I would argue that the problem actually begins within that first 3 to first 5 days following delivery. There's good evidence that if a mother does not produce sufficient amounts of milk in that first week, she's going to stop lactating earlier than those that feel that they are producing enough milk. Mothers that come to volume, if they're mothers of very low birth weight infants, by day 14, and coming to volume means at some point in that first 14 days, the mother reaches 500 cc's per day. We know those mothers lactate longer. And we also know that mothers that have delayed secretory activation, or in other words, their milk coming in or lactogenesis stage 2, have decreased milk production, and that does not go away. That's continued their entire lactation duration. And this is a big problem in many of our mothers. And in fact, 85% of mothers that deliver preterm have either impaired or delayed secretory activation. Next slide, please. So I think since we know that early milk volume correlates with later milk volume, that these early strategies that I'm going to talk about are critical for adequate milk production. So it's kind of a critical mission. Next slide, please. So I think that there are 2 different mechanisms that we need to talk about. The first one is time to initiation of milk removal. And I think you guys are really looking at that and trying to improve. Can we get it down a little bit? Can we get it within 6 hours? And that's initiation of milk remover by either breastfeeding or, if mom and baby are separated, milk expression. Next slide, please. But I think many of us, at least I know what I do in my hospital, and as I talk around the country, we're so focused on initiation of milk removal that we don't pay attention to the rest of the picture. And I think that's only a small piece of it. I think after we initiate after delivery, we have to continue that milk removal. It doesn't count if you just initiate early if you don't continue expression or continue breastfeeding. And so there's something called a feedback inhibitor of lactation. And some people say that this component may or may not exist. But I think it really shows a nice picture. So if you have infrequent pumping, infrequent breastfeeding, that feedback inhibitor of lactation remains in the breast. It goes up, the levels go up, and you have decreased milk production because the body thinks that you're weaning. If that feedback inhibitor of lactation in the breast goes down because you're frequently removing milk, then you have increased or sustained milk volume. And so I think if you don't focus on frequent milk expression, you're very likely to have an insufficient milk production. Next slide, please. So it's a package of early interventions, and that early expression or early breastfeeding is just a small piece of it. Next slide, please. So recommendations, these are our best guess. So, it's our best guess because there's not a lot of literature regarding this. And the literature that we have really has some problems because I think individual mothers, each mother's individual, each mother has different comorbidities that affect her success. So time to initiation, our best guess is you should start breastfeeding within 1 hour and start pumping within 6 hours. Probably the earlier you can start pumping, the better. Frequency, breastfeeding 8 to 12 times per day and pumping at least 5 times per day. And I don't even really like to put that up there because I think the literature that supports that is later on in lactation. And I think we really need to focus on pumping frequently within that first 3 to 5 days. Next slide, please. So there's several different methods of milk removal. There's obviously breastfeeding. There's hand expression. There's a variety of different types of pump, obviously with the hospital grade pump being the most efficient. Next slide, please. There's also hands-on expressing, and this is when you're not only expressing, but you're also massaging the breast and your hand expressing while you're doing pumping as well. And you can look at this as well to kind of see how does that work? How can you teach moms to do this? Next slide, please. So what's the evidence? Hand expression is very effective for colostrum removal, and it's very effective for that initial expression. So say a mom has had a C-section, it's very sleepy. It's beneficial for that first expression and maybe for the next few expressions, but you really want to combine that hand expression with some type of pumping mechanism. Lucier in 2015 found that if you only hand expressed for the first several days, that you really negatively impact milk production. Hands-on pumping, there has been one observational study that shows that it may increase milk production. If you're looking at how should moms pump, there has been some information regarding should moms should pump at the same time, both breasts at the same time. While that may increase milk volume, it may not be statistically significant. However, if you pump both breasts at the same time, you do it in less time, which may be beneficial for moms that are either working or have babies in the NI. But when you actually talk with moms, if they don't have some kind of fancy wearable pump or some fancy bra that holds the pump within without having to deal with her hands, she really likes doing one breast at a time so she can do something with her phone at the same time. There has been some evidence that looking at that total duration or minutes pumping or breastfeeding in a 24-hour period may increase volume later on. Next slide, please. So I think there's barriers, and there's really significant barriers. So if we want to help moms remove milk and remove milk frequently, we have to consider these. So there's C-sections. There are moms that are preeclamptic that are on bed rest. There's moms that are preeclamptic who are on magnesium sulfate. And I don't think that we can expect these mothers after that first expression to leap out of their bed and begin independently expressing or independently breastfeeding. They need some type of assistance, probably for about 48 hours. Now, that assistance could be an RN, it could be a lactation consultant, it could be a tech, or it could even be the family. If we can provide some education to families, perhaps they can be expected to really facilitate increased milk removal through until the mom is able to go home or is able to independently breastfeed or express. And I think and depending on where you work, so if I look in my practice, I think that we have very, very, very few moms that are not overweight, that deliver vaginally, that can leap up and independently, with no comorbidities, independently express or breastfeed. We have very few of those. And as our moms get more and more heavier and we have more and more diabetes, this becomes more and more important. Next slide, please. And I think one thing that this is well recognized is the significant disparities that we in the United States experience with lactation success. So we know that there is significant racial disparities among mothers. And this is unfortunate because not only do fewer Black moms breastfeed or provide mother's own milk to their infants, they are more likely to deliver preterm. They have more likely a higher incidence of maternal morbidities that may be benefited from lactation, and their babies have an increased incidence of significant mortality and morbidity. So there's a lot of work, and we don't have time today because I think this is a huge issue that needs quite a bit of work. But there's also socioeconomic disparities. So those moms that are poorer have less success with lactation, and geographic. So all of us that live in the South, women that live in the South don't have as much lactation success as well. And there's also comorbidities, and sometimes these comorbidities are significantly issues. So diabetes, obesity, hypertension, we know that these mothers experience difficulties with lactation. They have delayed secretory activation. It's more difficult for them to breastfeed or express. And so this is a population that we really need to spend quite a bit of time with. Next slide, please. So as I transition to Sandra, who's really going to talk about how do you institute some of these changes on an institutional level, I want to talk about how important healthcare professionals are. Number one, mothers receive conflicting advice. And I think that happens, at least it happens in my hospital. I may tell them one thing, the nurse tells them something else, the physician tells them something completely different, and then some person like a physical therapist is going to come tell them something completely different. And that's not where we want to go with this. We all want to be on the same page. And healthcare providers really lack true evidence-based lactation education. And if they have good evidence-based lactation education, we know that it affects their attitudes and knowledge. And we know that with knowledge and attitudes, we can either support or we can inhibit the lactation success of the mothers that we work with. And on that note, I want to transition to Sandra and let her take over.
Thank you, Leslie, and thank you to the Georgia AAP and Georgia PQC for inviting us. I'm so excited to be here. So we are one of the institutions that went through a quality improvement project several years ago, working on our breastfeeding rates. And so a lot of this I am bringing to you from the experiences that we went through, trying to move our breastfeeding rates from nobody knows because nobody measured, and what is M pink? What is that? Who fills that out? Where does that come from? To now, we know who fills out the M pink, when the scores arrive, and we track those. So hopefully I can help very quickly take you through 10 years of experience. It was a project that the actual project went over 2 years, so similar shortened time frame. Very challenging, very exciting. Love the collaboration. You know, we said deal shamelessly. Dr. Patel said institutions that want to develop policies, and I remember that triggered me. We never use the D word. We steal, we share, but we never develop. It's already out there. Somebody's got it. So I hope that you guys will find this helpful. I started based on the new policy from the AAP. Since this is an AAP project, I thought we should highlight that. It's not a new policy, it's an updated policy, but in it, they really hit on a lot of the evidence-based maneuvers and recommendations. And so for the purposes of reference, I give you the policy statement, which also then references many of the statements and evidence that they base their things on. So it's a great overall resource to then go digging and find your specific studies to look at whichever particular project you want to support. Next slide. So in the AAP updated policy for breastfeeding, they reference and give a shout out to the Agency for Healthcare Research and Quality, AHRQ, if you've heard any of their webinars. AHRQ looked at all of the evidence and came out with these conclusions. And I have to tell you, when I started neonatology, I moved from the hospital where I trained to a hospital that was much more breastfeeding friendly, and people talked about baby friendly, and I wanted to vomit all the time because I didn't understand it. I didn't know it. It frightened me. And then I learned a lot more. And through many years of lots of education, I have started to not have a visceral reaction when people say baby friendly. And we are now a baby friendly institution. So I by no means think that everyone should be baby friendly. We should all be breastfeeding friendly. And so as we go through this, just I recognize where many people are, and I've felt all of those emotions along the way. But the Agency for Healthcare Research and Quality said the Baby Friendly Hospital Initiative increases breastfeeding initiation and duration. And those are really the two key points we want to do. You have to start to endure, but you have to continue and maintain for the benefits. And the Baby Friendly Hospital Initiative really is just an external certification that you have done all the things that lead to this outcome. So, you know, it's like many of the other hospital certifications, like magnet certification and other things. It's an external validation that you've actually done these things. So in the article, in the policy, they also say that education is very important and does lead to change, but education of the staff is insufficient as a single measure. So we are very important. All of the staff is very important, as Dr. Parker mentioned, for helping or hurting breastfeeding success to any particular mother. But educating us is not enough. I wish that the departments of health understood that for NAS. Educating the doctors is not enough to end our epidemic of narcotic use. But education of staff is not enough as a single measure. So what else? Well, these are practices that have been shown to improve breastfeeding rates. Skin to skin, early after birth, regardless of mode of delivery, whether it's C-section or vaginal delivery. Early skin-to-skin contact decreases the risk of hypoglycemia, which is one of those things that causes people to get something other than breast milk sometimes for their first feed. Breastfeeding in the first hour of birth increases breastfeeding rates. Exclusive breastfeeding, so no supplementation, improves breastfeeding rates. Rooming in improves breastfeeding rates. Breastfeeding on demand improves breastfeeding rates. Avoidance of pacifiers improves breastfeeding rates. Information on breastfeeding support after discharge improves breastfeeding rates. Well, that's 1, 2, 3, 4, 5, 6, 7 things that sound vaguely familiar, don't they? The Agency for Healthcare Research and Quality, AHRQ, also did a systematic review of over 40 studies and concluded that breastfeeding supportive practices were associated with improved rates of breastfeeding initiation and duration. So there's lots of evidence out there for you. Next slide. So we're going to talk about these, the 10 steps. I'm not going to say baby friendly anymore after that last slide, but we are going to talk about the 10 steps to successful breastfeeding. Those 7 things I read off sound vaguely familiar to a lot of things that are in the 10 steps. When we did our QI project, it was basically going from a hospital where all babies went to the nursery to be observed for 4 hours after delivery, no matter what, 4 to 6 hours. And we had 1 lactation consultant on staff for about 3,000 deliveries and a 50-bed NICU. So we were really far from any of the 10 steps. We started with 0. And so we had really far to go. So I'm gonna just walk through with you on things along the steps that mention those steps that were important, and in polling some of my colleagues in lactation and nursing about, this has been 9 years now since we did the project. So trying to help me remember what were some of those things that were hard, because some were easy, some were hard. So next slide. So staff competency, and as we said, education is critical, but it is insufficient alone. The key part, I think, is staff is more than just the doctors and nurses. It's everyone. So ideally, somebody should understand, everyone in the institution should understand that this institution is committed to breastfeeding. In the floors, your NICU, your mother-baby, your labor and delivery, antepartum, those areas should really, it should be everyone who comes into contact with any mom. So that's the doctors, the nurses, the clerks, the nursing assistants, the housekeeping, the dietary, the OT, the audiology, the birth certificate lady, or person. Anyone who comes into contact with a mom should have a level of education to the extent that their job requires. So the nurses and lactation consultants are going to have a different level of education that's required from the birth certificate staff or audiology or OT. The physicians generally have a different amount than the nurses and the lactation consultants, but everyone should have enough to know that you don't walk into the room, see a crying baby and maybe a crying mom and say, just give that baby a bottle. Why don't you feed him formula? Your baby's starving, right? Right there, they're done. They're done. She's just completely torpedoed this mother's chance of success, she or he. So educating everyone is really important for whatever their goal is going to be. The next step in these steps that required a lot of effort and energy is the immediate postpartum time frame. So doing skin to skin immediately that lasts preferably through the first breastfeed, or at least 1 hour, or as long as is medically reasonable for babies who are preterm or have congenital anomalies, or for some reason need to go to the NICU. So for instance, we oftentimes have babies with congenital heart disease that are born that we encourage to stay with mom for 20 to 30 minutes because no one needs PGE in the delivery room. So they can stay for a few minutes while we're getting everything set up in the NICU. They do skin to skin. I encourage them to breastfeed because once they come to the NICU, that is never happening again for quite a while. Maybe not never, but it is a challenge at times depending on their heart lesions. So that is the only chance this family has for any sense of normalcy. And we try to start that off and let them stay there and encourage them to breastfeed. And then that's that first expression. And then we can move on to, you know, getting mom to pump. We include, I didn't include this in here because it's not necessarily one of the things, but the prenatal education is one of the steps that's important, letting people know what to expect, and depending on their situation, what to expect when they come to the hospital. There's a lot of debate out there right now. I don't have data for it, but there's a lot of things happening where in the moms groups and moms communicating with each other about antenatal milk expression, especially for women with diabetes or risk for gestational diabetes, risk for hypoglycemia, any baby that's going to be at risk for that. There's a lot of antenatal milk expression, which the OBs get very concerned about sometimes. And it does, you know, there are risks, but I feel like that's one of those things that should be openly discussed with their obstetricians ahead of time. And that may assist with your first feeding of being breast milk if your institution isn't one that uses donor milk in their well baby area. That some moms come in with a fair supply of expressed breast milk that can be used when their baby gets hypoglycemic. But that first skin to skin, immediately after delivery, including the PACU, post-op, in the OR. I know when I'm lucky enough to go to the deliveries that are relatively normal, as a neonatologist, it doesn't happen very often. When I go, I bring those babies, put them skin to skin right away, and sometimes even try to work on getting them to latch while the OBs are closing the mom. It gives everyone something else to focus on, right? It gives the mom and the dad, they take pictures. It's all very lovely and it feels as normal as it can be. Our anesthesia colleagues are great photographers. So it can help, especially those moms who've been wanting not an instrumented delivery, to feel like they didn't lose that entire normal experience of delivering their baby. And then doing meds and assessments while the baby is skin to skin with the mom. This is a huge, especially when we get called to a delivery, this was a huge step for the nurses and pediatric residents that I train, and sometimes the nurse practitioners who come to the deliveries, to move from every baby that we get called for goes to the warmer for us to assess, because we put them on their backs, we look at them and we listen to them and we measure things, and this is how we do it. To we can listen to the baby, we can assess the baby, we can look at the baby, we can assess for respiratory distress, we can listen to the lungs, we can listen to the heart, we can see the skin color, we can see retractions on the mom. So when I tell the residents, you can do this, just you can go to the mother, and they look at me like, how? Take the stethoscope and go over to the mother. So that can be done. In fact, giving the meds like the eyes and thighs while the baby is on the mother, you know, being with the mother is nurturing to the baby. Like breastfeeding, it has its own little pain relief, so it is less disruptive. If the mothers are willing, someone don't want to hear their babies cry. That's a whole nother issue. But it is one of the things that helped keep us from having to take the babies away, was learning to do all of those assessments with the babies on the mom and people's comfort with that. We already mentioned sort of the support for breastfeeding and consistency. We talked about inconsistencies in information. One of the things that we put in our policy, and we had one policy that kind of covered all of that list of policies that you all were auditing. You know, there are some great models out there, and ours, you know, has everything included in it. So it's one policy that has subchapters of everything in there. And one of the things we included was whether or not we were going to accept outside training for lactation. And we decided not to, that everyone should have the same. So even our lactation consultants, myself, who has an IBCLC, that didn't matter when it came to, have I done my training? I had to do the 3-hour training course for physicians. Every lactation consultant had to do the 20-hour course for nurses. So the consistency, making sure we're all starting at the same foundation, and then giving everyone the same information. People interpret things differently, and then people have different confidence and comfort levels. So one of the things we found very helpful early on, and still whenever things come up, but very early on, was scripting. And finding scripting to help with those conversations that people weren't comfortable with. Supplementation and pacifiers and the risks of formula are some of the ones that really were struggles. You know, and the pacifier one really is a trigger for me that I just try to turn around a lot when people say, oh, you don't want him using you as a pacifier. And I say, well, actually, that is his job. The baby's job is to suckle, and your job is to be suckled in those first couple of days until your milk comes in. This is how your body knows there is a baby who needs to eat, right? Because not all the time was it successful that mothers lived and babies lived. So this is the baby telling your body to make milk for it, because the mother's body goes through a lot of energy to grow the baby, but then it doesn't need to invest in the additional energy to make milk unless there's actually a baby to feed. So I explain it to the moms, like, there's the factory gets built during pregnancy, and there's a skeleton crew on staff. And it's not until the orders start coming in that they need to start up-regulating production and really start making milk. And so the baby's job is to suckle all the time. You're not a pacifier. You're the mother, you're a lactating mother. As your milk comes in and as things regulate, that will go down, and you won't be having to be suckled all the time. But that's kind of the role right now. And that's normal. And just re-emphasizing what is normal, it can be very helpful. Next slide. Supplementation, you know, is a huge topic, and you guys are looking at that specifically. So there are reasons, medically indicated reasons. The new policy, the updated policy, actually says that any supplementation, specifically hypoglycemia is the primary one, but any reason for supplementation should be supplemented with expressed breast milk. And if there's no expressed breast milk, then babies should be supplemented with pasteurized donor human milk when it's available. And they reference that formula supplementation has been associated with increased exclusive formula feeding, so quitting breastfeeding by the time of discharge when formula is supplemented. And that comes directly from the AAP policy. I do want to throw a little plug out there that we in Florida just passed this year a law. We did some work here at UF and USF, our colleagues, on donor milk use in the NICUs. And then there was a bill in the legislature which didn't really reflect the information from the project that the legislature asked us to do. So we went back and we kind of back and forth until we came up with some verbiage that eventually got passed. And so as of July 1st, donor milk and its derivatives are a separate reimbursable covered expense from Florida Medicaid. So I highly encourage you, I know you've talked about advocacy, that's another route, because access to donor milk I think is one of those things. We've talked about how important human milk is, and we say use donor milk, but many states don't pay for it. And so then it's up to the hospitals to decide, and costs get cut, or maybe your hospitals with lots of extra money can do it, but your hospitals that take care of patients that don't have a lot of insurance maybe can't support that. And so it just continues to widen that gap in health inequities. And so from the face of inequities and access, I think if that's something that you're interested in, I'd be happy to talk more about that offline. And then after mom's milk or donor milk, then we have glucose gel, and then formula or IV dextrose. And I think that comes into shared decision making with the mom. There are some moms who would rather have their baby have an IV. And I've had colleagues look at me and say, why? And I mean, I would rather have my baby have an IV than be given formula, depending on what the situation is. And sometimes that's not the answer, but I think that those are discussions that we don't they both have different risks and different benefits. Oh, donor milk inpatient is covered by Georgia. Oh, you guys are amazing. Congrats, good work. So other things for hypoglycemia, we had trouble with first dose education and documentation whenever there was supplementation required. So making it like any other medication. And then just a general practice is delaying circumcision for those babies who aren't feeding well. We know that following circumcision, a lot of times babies don't eat quite as well and they need a little rest period. So if they're not feeding well, maybe delay that off a little while, or even be done as an outpatient if that's available to them, especially those late pretermers. We know they're going to peak their bilirubins later. We know they're not great eaters. Anything that stresses them, kind of try to delay that out a little bit. So why rooming in matters. A lot of the things we do right away, or we used to do right away, was, again, babies went directly from the delivery room, whether it was vaginal or C-section, to the nursery where they stayed under a warmer being monitored, and then they got a bath, and then they went to their mom's rooms. So along with early expression, rooming in allows early and frequent breastfeeding access. We delay the bath until we do it 24 hours. The AAP policy says at least 12 hours. So giving a good amount of time for the mom and the baby to be together, to learn feeding cues, to do a lot of skin to skin continuously, as long as they're not on medications that make them unable to care for the baby, or there's someone else in the room. Doing assessments, as we said, immediate postpartum assessments on the mom, and then later on in the day, doing pediatrician and nursing assessments in the room. So instead of the babies coming to the nursery for the pediatricians to examine, and for the hearing people to do the exam, and for the nurses to do their assessments and give their Hep B, that would sorry, I was reading the chat. Leaving the babies in the rooms all the time allows the babies to still be with the moms, and for the moms to be able to recognize the feeding cues, or for the nursing assessments, or if they're going to do PKU or something, they can help with pain management by nursing. But that constant communication and easy location, that they're near each other. When there's separation, then we have to go to expressing milk with hand expression or pump expression, or the mom being able to get up and go to the NICU and put the baby to the breast, depending on the situation. All of the things like hearing screens and car seat challenges, Hep B shots, all of that stuff done in the room was very helpful. And I put an asterisk for hearing screens because that was one of our very first, sort of after our baseline data of looking at our rooming in numbers, or we looked at 23 out of 24 hours with the moms. What were the biggest reasons, the top 3 reasons that babies came out? And they were hearing screens, circumcisions, and assessments, pediatrician and nursing assessments. And so they have to come out for circs. We don't do the circs in the room. I think that's just fair to everyone, though I would happily do it in there if they wanted. But in general, the practice is they still come out for circumcisions. Other than that, we talked to the audiology and said, can you do hearing screens in the room? And they said, why, yes, we can. And that fixed that. So that was an easy one. They just started doing hearing screens in the rooms. Getting the pediatricians and the nurses to do it, a little bit more education and discussion, but it did happen. In the chat, someone said they don't allow rooming in with IV dextrose, and I agree that is also the case for us. So if they get formula, they can stay with mom, but if they get IV dextrose, they come to the NICU. So that's what I mean when I say they both have risks, because that would require separation, but not formula exposure. So depending on where that mom's value is in proximity versus exclusivity. But she may have a different feeling than the provider taking care of her. So that's where I come to the shared decision making. and making the best choice, because I don't think we technically have an answer that one is profoundly more effective medically. So laying it all out and discussing it with the family and having their buy-in makes things a lot easier. But I agree, we don't also get babies in the rooms with IVs ongoing. Next slide. So ad lib feedings without limits. We put a little, babies can't tell time, and put prompts on the whiteboards in the rooms so that moms can remember to put the information up there. But we really got away from the every 3-hour feeds, unless you're in the NICU, to more feeding on demand. The bottles and pacifiers for early things, that was one of our early steps where we just moved all the pacifiers into the Pyxis so that somebody had to go in and actually get them. That was an easy change. And again, it comes back to that whole, the only thing I can think of here where it would apply to your early expression is that if they deliver at night, that is oftentimes a time when that early period may require a bit of support, and the staff to support are not always as supportive at night, and things tend to happen at night. And so making it a little more difficult to just use a pacifier supplement and not actually go and help with the breastfeeding can help in that early period. And then resources for everyone. And I figured this should be one of those like 100%, because it doesn't matter how you feed your baby, every mother needs resources. And then you just include the lactation information, because some of those moms get home, then they get engorged, and then they decide, oh, I think I'll breastfeed now. So getting help will be helpful, or knowing where to find the help is important. Next slide. So, oh, it got cut off. That's my baby, Catherine. Special considerations for the NICU. So we know skin to skin and kangaroo care are evidence-based. There's a positive effect on duration of milk production and other outcomes. And then this is an argument that, not an argument, this is a topic that I tend to talk about a lot on rounds, direct breastfeeding. One time someone asked me, well, is there really evidence for that, or is it just a nice thing to do? Well, no, there's really evidence for it. That the initial oral feed at breast, frequent breastfeeding, earlier gestational age at breastfeeding are all associated with longer duration of breastfeeding, both during the hospital and after discharge. Putting babies to the breast as early as 31 to 33 weeks, depending on their stability, is possible. We say you can go, we don't expect them to do a lot, but the more they're there, the more likely they will breastfeed. And then having at least one direct breastfeed per day in the NICU before discharge is helpful for prolonging. So yes, feeding at the breast is important. And as you're looking in your NICU about measures, this is one of those things you may want to look at. It's not early expression, but it's the first oral feed being at the breast before you introduce bottles later on down the road can really make a difference for that mom's breastfeeding success. Next slide. I promise I only have a couple more. So take-home points for NICU are very similar for the regular nursery that you already heard from Leslie. Express early, aiming for 1 to 6 hours after delivery. Express often, aiming for 8 to 12 times. And what we learned from some studies is express however they will, whatever they can do. Early on, hand expression, hands-on expression, great for colostrum. Later on, pump with hands on. Whatever they are willing to do, encourage them to do. Kangaroo care, skin to skin, as early and as often as possible. Direct breastfeeding, first oral feed, and then whenever they are able, whether it matches with a feeding schedule in the NICU or not. And then, it takes a village in the NICU and outside. The education and empowerment of everyone, including the support people, is important in the NICU. Next slide. So this is a QA project this looks like it has nothing to do with what we just talked about, but I revert back to this every time, as Dr. Parker can probably attend. Every time we have a meeting and we talk about doing something, I say, well, what's our PDSA for this? What's our project? And so many times you have to go back to start small. So when we did skin to skin after C-sections, we started with one nurse, one day, one patient, and we did that. And then we met and figured out what went well, what went wrong, what needed to be changed. We adapted it. The next time we did one nurse, one day, two cases, and we talked about it, fine-tuned it. And then the next time we did one nurse, one day, all of the C-sections. And so we, kind of made it more broad scale at each time. So whatever it is, some of those things like locking up the pacifiers was easy, one time and we're done. But some of the things required a fair bit of, I'm sorry, my formatting got all messed up. Some of them required a fair bit of repeat, adapt, repeat, adapt, repeat, adapt, and implement. And then, once you do adopt it and try to implement it, then it's that ongoing situation where you're doing your audits and you're re-educating. And I feel like that it's just constant. You audit, you re-educate, you practice for a while, then you audit and you re-educate and you practice. And it's just continues and continues and continues, which is why it's called continuous quality improvement. So find your low-hanging fruit, start there, get some wins, and then remember to stay small. This isn't research. This is quality improvement. Start small, and then adapt, repeat, adapt, repeat, adapt, repeat, and then adopt and implement. And I think that's all. And I think we went a few minutes over. So thank you so much.
That was awesome. I love this final slide. That's great. Just a great way to end. Thank you all. Thank you both so much. That's a lot of information that our folks can take back to their teams.
Thank you very much.
Are a little over time, but if people are able to stick around, and if you have any questions to ask, or you can put them in the chat, or you can email them to me, and I can always pass them along to Dr. Sullivan and Dr. Parker if you have to go. So as you think about that with questions, just a little reminder, oh, I didn't change the title. That is not our title for September for next month's webinar, but it is on September 13th. I did get that right. And for our data leads, our August audit is coming out on next Monday, the 22nd. So be looking for that. And as always, if you have any questions, you can email me. My email is right there. So if anyone have any questions in the chat. Yes, we recorded this webinar, so it will be posted on Teams. I'll send a recap email out to everybody. It'll have a link to that recording. And then we will, if it's okay with our speakers to share slides, we can PDF the slides and have those available as well. So yes, we'll have those up. Any other questions? All right. Well, if you think of any, please do send them my way. I'll pass them to our speakers. Thank you again so much. This was a wonderful way to spend the afternoon. I really appreciate you all being here. Thank you for attending, to all of our teams, and we will see you again in September. Thanks, everybody.
Thank you.
Thank you.